Welcome to another episode of the Doctors and Dollars podcast, where we discuss health insights and wealth secrets. I'm your host, Nate Crannell, joined today by Dr. John Ludlow. John is not only a urologist of nearly 30 years, but also a runner, a cyclist, and a men's healthcare advocate. He focuses on wellness and disease prevention, as well as sexual dysfunction, testosterone deficiency syndromes, and benign prostate diseases. With a more defined focus on patient communication, preventative care, and patient outcomes, he understands the need to leverage technology to facilitate this change across the healthcare industry. Welcome to Doctors and Dollars, Dr. John Ludlow. How are you?
Yeah, real good, Nate. Thanks for having me. It's a pleasure to be here.
Usually I ask at the beginning of every episode, what's going well today? And I just asked you offline, what's going well? And you just got back from surfing in California. You really can't argue with that.
No, this is, having grown up in Southern California and surfed most of my life, I'm now in Michigan and Minnesota. There's not much surf in Michigan and Minnesota, at least not surfing on the water. So it's nice to recharge, head back to California, sort of commiserate with the guys I grew up with, and it really it's a good cleansing of the mental health, if you will.
That's awesome. How long have you known these guys?
I've known these guys since I was about 5 or 6 years old, and
Wow.
they're all really good friends and do a really good job about keeping people together. So I'm fortunate.
Yep. I'm just back in Michigan for work now and just ready to brave those winters.
Yeah, we spent our time in northern Michigan, and then we have kids in Minneapolis that get us over to Minneapolis because those kids are having kids. So we kind of, I like to say we winter in Minneapolis, which is, a crazy thing, but actually Minneapolis is a good city. We've enjoyed it.
Yeah. I mean, it's tropical, right? I mean, no better than going from northern Michigan over to tropical Minneapolis,
Yeah,
in
exactly.
October, November. Yeah.
Yep,
And
you're
I'm
right.
here in central Iowa, so I can certainly appreciate all the four seasons that we get to enjoy.
You know,
Absolutely. Versus, I mean, the perfect season of Southern California. Were you in the LA area or San Diego? Where'd you grow up?
I grew up in Manhattan Beach, which is a little suburb outside of Los Angeles. It was this quaint little beach town for a long time, and it's completely different now.
Commercialized.
Yeah, it's a lot of big homes and celebrities and athletes and things like that, which is fine. I mean,
Mhm.
everybody, it's a great area. But it's LA too. It's a little bit. I'm in northern Michigan where there's no such thing as traffic. So I head back
Sure.
to LA and I get a dose of the 405 freeway.
Yeah. And I think I told you when we first talked, like your practice was in Holland, right? Holland, Michigan, Western
Holland,
Michigan.
Michigan. Yep,
Man,
Southwest Michigan.
one of my favorite towns in that whole state. It's a cool town. Between that and South Haven, I think those are tied for my favorites. I think that's just a cool area of the country.
It really is. It's a really unique area, that Holland, Saugatuck, Douglas, South Haven corridor. It's
Hmm.
really it's a great area, and it's thriving. It's interesting. It really kind of exploded with COVID because Chicago people sort of vacation in the Holland, Saugatuck, South Haven area, and a
Hmm.
lot of people, because of remote working, move their lives to that area of Michigan, and it kind of blew up in the wintertime. So it's
Wow.
changed a little bit.
That's pretty cool. Well, I know.
Yeah.
So you had your practice there in Holland. Recently, you've cut back hours to focus on family. You mentioned your grandkids over there in Minnesota. You've mentioned before that you would like to see a men's healthcare center that really caters to the 20 and 30 and 40-year-olds. Guys that are more my age. I'm 35. Just like they would, cater to the guys that are 50, 60, 70-year-old. As we think about
Exactly.
prostates, we think about anything urology related. Do you feel like the practice that you and your partners have built there in Western Michigan, have you created a center like that?
Yeah, it's really a great topic because things have changed.
Hmm.
Guys my age, I'm in my 60s, so guys my age sort of saw their pediatrician till they were about 15 or 16, and then they didn't see anybody till they were 50 or 60 and had some sort of
Yeah.
issue. I think the younger population, the guys that are my son's age, in their 30s and 20s, 30s and 40s, I think they're more focused on some prevention and wellness and making sure that they don't get to be 50 or 60 years old and are behind the eight ball when their health explodes. So I see a lot of younger guys that are really interested in health maintenance and prevention and wellness, and also they're interested in approaching healthcare a little differently. They don't want to make phone calls and call the office and wait in the office. They want to do everything electronically, which I think is a really good thing. And we've had some slow adaptation to that, to be honest with you. It's been a little bit of a struggle to break out of our habits of writing things down on paper and scheduling
Hmm.
office visits and doing things like that. So we're changing with the time. We've been pretty good about recognizing how that has changed, and it's helped us. It's from a practice standpoint.
Yeah, so talk about the preventative. I mean, like I said, I'm in my mid 30s. I'm guilty of what you said earlier, kind of getting that checked out when you're in, your teen years, and then you don't see anyone until you're 50. I kind of know that
Right.
first prostate exam comes when you're 50. It's kind of that
Yeah.
doomsday age.
Yeah.
What are some of those preventative things that you feel like a lot of my generation is focused on? And what are some things that they're doing that they don't really need to focus on, and what should they be?
Well, good points. I think the key thing are simple things, not smoking,
Hmm.
diet. What's diet is a struggle for a lot of people.
Sure.
The convenience of fast food and processed food and prepared meals. It's amazing. This stuff tastes good. It's quick. It's relatively inexpensive when you think about the time it takes to cook something. But
Hmm.
diet has been a real big part of this whole process. I think a lot of the patients that I see have gone away from a heavy meat based diet and have gone more to a plant based diet. And I'm not talking vegan, militant vegetarian stuff like my
Hmm.
wife. But talking about more sensible diets, a little bit more in the way of fruits and salads and things like that, avoiding processed foods, being more cognizant of avoiding things like Coke and Pepsi and Mountain Dew and those types of things.
Hmm.
So I think that's been a big part of it. Also, I think regular exercise has become a little bit more of the mainstay, and I think the younger guys are more understanding of the fact that your exercise regimen doesn't have to mean you're planning to do a marathon or an Ironman or something
Sure.
along those lines. I think it's regular exercise to up your heart rate and sweat a little bit 3 or 4 or 5 times a week. The two other things that I think are important that I've seen people talk about sort of prospectively to me is stress reduction and good sleep habits. I see many more people meditating, yoga, that type of thing for stress reduction.
Yeah.
And the struggle of sleep has been an ongoing issue. It's there's all sorts of those sleep apps and the sound, the white noise machines and things like that. But it's a big focus that people are really interested in understanding what it means to have a good night's sleep and how important that is.
So two questions there. I'll touch on the one you just said. Sleep. Is it more important to get a consistent 7 to 8 hours, or is it more important to really recover yourself if there is the night where you're out with friends until midnight, you don't get a lot of sleep? Is it more important to catch up that next day? What is it, more of a
Yeah,
pattern, or is it more of just a recovery?
yeah. I think there's all sorts of data, but there's been some good information about that 7 to 8 hours of good sleep with a certain segment of rapid eye movement sleep. There's estimates of an hour and a half to 2.5 hours of REM sleep. Those can be that stuff can be a little bit of a struggle. From my
Mhm.
standpoint, when I was in residency and in really in my practice and working hard, 3, 4, 5 hours of sleep of a night of sleep was not uncommon. And
Mm.
it's hard to recover from that, and it's hard to catnap during the day and catch up on that good quality sleep. So I think it's important to to reach a point in your day where you're gonna wind down. You're gonna give yourself that time and understand the importance of a good night's sleep. It's
Mhm.
really changed, I think, the mentality a lot. Like I look at my kids. My kids are all hard grinders and work hard, but they're also very very much more interested in a good night's sleep and doing things like a good mattress and a good pillow
Sure.
and and the white noise and things like that. So It's changed. We're really understanding the necessity of a good night's sleep.
That's yeah, and not something you think that a neurologist would know a ton about, but or a urologist, excuse me. And so I think it's great that just that health and wellness aspect of sleep is so important to the work that you do.
It really is. Sleep's valuable.
For sure. The other thing I was thinking on is as you were talking there, was around diet, and you've seen people move out of the more meat-based diet more into the not vegetarian, but a little bit heavier fruits, vegetables, and things like that. I know that disease and things like that are it's a malfunction or a it's impacted by protein, correct? So is there any type of correlation between somebody who is more meat focused, and I'm asking more for me because I'm definitely a meat and potatoes kind of guy. I mean, we are having some type of protein with nearly every meal. Is it important to have good protein in your diet versus is it better to go the route that you were talking about, a little bit less protein, more on the fruits and vegetables, that kind of thing? Is there any correlation with disease and a protein based diet?
Yeah, I think that's a really good question, really good points, because I can't stress how important protein is for our overall health. And I'm not really a big fan of high protein diets, but quality protein is important.
Sure.
I'm not looking at people or talking to my patients and saying, listen, you got to cut meat out of your diet. I think having red meat is fine. I'm a little bit, the processed meats like bacon and things like that. I was on this camping trip and had bacon last week, which I rarely do because my wife is the militant vegetarian. But man, it tastes good.
Yeah.
But quality protein, I think, is really important from the standpoint of overall health. It's really important from the standpoint of recovery from any sort of exercise we do. I think different types of protein supplements are important, but you can get that from a really solid, good diet as well.
For sure. So let's talk about the T word, testosterone.
Yeah.
As I progress, I guess, from my mid 30s into my 40s, you get closer to the kind of that later stage in life that I imagine a lot of your patients and people that you see are in that range.
Yeah.
Testosterone levels are decreasing. Are there ways for guys like me at 35 years old to slow down that decrease of testosterone now, or are we all just kind of doomed to take those low testosterone pills that Frank Thomas and Doug Flutie promote?
Yeah, testosterone has garnered a lot of interest over the past 10 years. I can think of when I started in practice and when I was in residency, testosterone was the bane of urologic care. It caused prostate cancer. It made your prostate grow, and it had all these negative connotations to it. And if you look back, there were two physicians in the 30s that won the Nobel Prize in medicine for identifying the fact that that prostate cancer will sort of involute or die if you take someone's testosterone away. That was one patient. One patient was in the study. They castrated this guy, and he had bad prostate cancer, and his prostate cancer got better. So the dogma was testosterone is evil and bad. And then things started to change, and we sort of understood the benefits of testosterone. It's hard to study, though, because you have to study large groups of people over a long period of time. I think the bottom line is that we all recognize that hypogonadism or low testosterone is a real disease process, and it can occur with age. Healthy diet, exercise, losing that body fat. It can be very important in maintaining your testosterone levels. But there are a lot of patients that I see. So I have 3 or 4 patients today with low testosterone and a lot of misunderstanding about testosterone. I think the other thing that's important is that testosterone has sort of garnered a niche industry. And I don't mean to be derogatory or negative, but there are these, I call them strip mall testosterone clinics that want to get you in, charge you a lot to test you, charge you a lot for the testosterone replacement, and then sort of toss you by the way. I'm probably overstating it, but I think the bottom line is that low testosterone is a real disease process. It needs a proper evaluation. It's relatively easily treated, and it has to be followed long term. I have a ton of testosterone patients who are so happy with being on supplemental testosterone, and we're doing it correctly and not overshooting, and their quality of life in many domains is much improved.
Would you encourage men who are experienced, they could just tell, or they've gone out and tested their testosterone and it's like, yes, I do have low T. Would you encourage them to come to a guy like you and have that supplemental testosterone and have a regimen for it? Or is it okay to go out and buy I don't know what it's called, those pills, Test Boost Max or something like that,
Yeah,
and just follow the instructions on that bottle?
yeah, it's a good question. I don't want to overstate it, or I think there's some benefits to supplements. Supplements, the problem with the supplement basically is that they just haven't been rigorously tested.
Yeah.
And sometimes that's a little bit overdone. The FDA says you got to follow certain rules, and supplements are a little bit outside that domain. But
yeah, they don't need approval, correct? Like they're not going out and getting FDA approved. Yeah.
Yeah, correct. So I'm not necessarily against them, but I think that you can be tested and treated relatively efficiently and relatively inexpensively, as long as you're going to someone that has an interest in doing this. I see a lot of patients that have been on testosterone for 3 years and they've had no follow-up testing at all, and I think that's really wrong. You really want to know where the patient is when they've been on testosterone, and I don't really look so much at the testosterone level as I do their symptom response. If you come in and you've got poor libido and no energy and no motivation and loss of muscle mass and maybe some depressive mood and things like that, sleep problems, and we put you on supplemental testosterone and you come back after getting tested, everybody wants to know what's my level. Am I 500? Am I 600? Am I 700? I want to be 700. And I say, you know what? I don't really care what your number is. It's going to go up if you're being treated. Well, tell me about your symptoms. Are you better? Do you have more energy, better libido, better sex life, more muscle mass, better recovery after exercise? Tell me what your symptoms are and how much better you are. That's really what I want to know to gauge how I'm doing and how I'm assessing them from a response standpoint.
Yeah, not necessarily the focus on the testosterone credit score, right? If
Correct.
700 is good, right? We don't care what your testosterone credit score is. We just want to know that, yeah, if you're feeling better, which is great. I think that's a great direction to go with patients. It's more feelings based, less analytical, right? And people can relate to that, because then you're truly asking them, like, how do you feel? Like, I don't care if your numbers are 900 and you have the highest testosterone in the world, like, you still feel like crap, and you, again, have no sex drive and have no energy. Something's really wrong here. So
correct.
That's a great approach.
The other thing, Nate, that's important is that there are some guys are on testosterone, and if you look at how testosterone comes from cholesterol, it's sort of a cascade of enzymatic reactions that produce testosterone. Well, the breakdown of testosterone is to estradiol, which is the female hormone. And some men have a very active enzyme that raises their estradiol, which is going to compromise their response to testosterone. So again, your level is fine, but you're not feeling well. Well, we need to check your estradiol level and maybe put you on a medication like anastrozole, which prevents that conversion.
So it is possible to supplement and increase their testosterone back to normal levels, right? If we're going to look at the analytical side. But also the true issue could be their estradiol levels. They could just be high in both now.
They could be. So evaluating things appropriately. When I see somebody who's got signs and symptoms of low testosterone and we evaluate them with blood testing, I want to know what their level is. I want to know their free testosterone. Some people are big fans of bioavailable testosterone. I sort of look at free testosterone more objectively. And I think that's an important parameter, because you can have a normal testosterone level and an abnormal free testosterone level, which is really the metabolically active component. So having that initial evaluation is important. The other thing that's important that people kind of skip over is, why is my testosterone low? Is it a testicular production problem? Is it
Mhm.
a pituitary luteinizing hormone problem? What's going on here? Why is my testosterone low? So understanding that can give us some hints about how to treat, and maybe we should be looking more in depth into pituitary issues, such as
Mhm.
benign pituitary masses can cause testosterone issues.
What does supplementing testosterone? So I just think back to, I used to be a big fan of bodybuilding. Not that I was a bodybuilder, but I liked, bodybuilding workouts and
Sure.
reading and doing research on those guys. If you think about like back when you were done attend or you started attending, we're talking what, the 80s, 90s range.
90s. Yeah.
Yeah, shooting up with testosterone, shooting up with test
Yeah.
was kind of a big thing. What
Yeah.
does it probably is marketed as a supplement, but like these guys are taking a lot of test, right? And they're injecting it more often than they probably should. What does
Sure.
that do to their prostate, to their, pituitary, all those things that drive growth? They're essentially amplifying it. What does it do? What's the damage that it does to a bodybuilder in the 90s that was doing that?
Yeah, there's all sorts of downsides. I think the most compelling things is that people are going to notice immediately are things like shrinkage of the testicles.
Mhm.
If I'm giving someone, and not everybody, but if I'm giving someone supplemental testosterone, I'm turning off their pituitary gland, and the pituitary gland is really what stimulates the testicles to make testosterone.
Mhm.
So you're really compromising that pituitary testicular axis, which is really important to keep healthy. We used to be big proponents of supplementing testosterone twice a week or every 2 weeks. So we
Mhm.
give a big slug of testosterone, and it's very stimulating. The testosterone goes up, and then it backs off over the next 2 weeks. And that created problems, I think, with shrinkage of testicles and some other
Mhm.
side effects. People would describe acne and on their chest or on their back. And it created some problems. It could also increase the activity in the bone marrow so that the red blood cell count goes up. If you think of the Tour de France cyclists,
Mhm.
professional cyclists, they used to supplement themselves with testosterone, and then they went to this thing called epopoietin or EPO.
Mhm.
That was sort of a Lance Armstrong thing. And what it does is it increases your red blood cell count so you can carry more oxygen. But the negative of that is that if you have too much red blood cell volume, you are theoretically at risk of a blood clot. So you
Mhm.
have to be careful and not overshoot things. So we've gone away from this once every 2 week slug of testosterone more towards a once or twice a week injection of a much lower dose. And it keeps you more at steady state. Guys that were doing the anabolic steroids and in the gym and really bulking up, there were all sorts of downsides. There was liver disease, and there were brain issues, and people really had problems. There have been some athletes who have abused anabolic steroids, testosterone type steroids, and had some really significant health problems. So it's something that I think you really have to have a good thought process about how to evaluate, how to treat, and how to follow. And you want to go to somebody who has a vested interest or an interest in this aspect of men's health, and it's really important.
Yeah, don't get it from your friend Jerry down the street that
Yeah, no,
that said
yeah,
it's worked well for him and he's got some extra needles for you.
yeah, exactly.
Nice. So I'm gonna switch. Yeah, we were talking about pituitary and those types of things. I want to switch gears and talk about the prostate. Right,
Sure.
prostate cancer is slowly rising, but technology and treatments have improved greatly. Somebody who got prostate cancer 30 years ago is not being treated the same as someone today. Why
No.
is it so important for men to keep an eye on it? Certainly themselves as they're getting into their 40s, their 50s, their 60s. But why is it also important for more doctors that are seeing these guys to advocate for prostate checks more often?
Yeah. Uh, think about let's just talk about numbers.
Sure.
In 2023, 275,000 men in the United States are going to be diagnosed with prostate cancer.
Wow.
30 to 35,000 are going to die from the disease. It's a big problem. It is the most common solid tumor in men. It's just behind lung cancer in deaths. The most common cancer in men is skin cancer, but prostate cancer is up there. It creates a significant amount of problems for patients, in regards to their overall health, obviously, their financial health, their ability to work, their ability to have relationships. And it has gone through a huge evolution in the last 20 years, more recently in the last 10 years. But it's really important I think it's really important to be screened properly. My feeling is a PSA every year or two with a rectal exam, beginning at the age of 45. If you're in that higher risk group, that means African American or a first degree relative, father, brother, who's had prostate cancer in the past, first PSA at 40. I saw a guy today, father died of prostate cancer in his 50s. This guy's 41 years old. He had a PSA of 1.2. That's a problem. A PSA of 1.2 in a 40-year-old with a family history of lethal prostate cancer, his PSA should be less than 1. So this is a guy that I'm going to follow really closely and make sure that we're on the right track with him. But getting a PSA, doing a rectal exam is important. The primary care doctors are overloaded with work. I'm fine with them they send those patients to me for a rectal exam, and they don't want to do a rectal exam. Fine. As I was taught in residency, the only person that doesn't get a rectal exam is the person without a rectum. That was the chairman of my program, John Donahue, who said that to me 50 times if he said it once. So I think it's really important. I do think that 10 years ago, the U.S. Preventive Task Force Service had advocated for no more PSA testing. They said it created more problems than it solved. And I think that was right to a certain extent. But I think some of the studies that concluded that for them were poorly done and incorrect. And it put us behind the 8 ball when it came to screening. In the last 10 years, I've seen more men with worse disease at presentation because of that. They've since rescinded that, and the American Urological Association has been a strong advocate of PSA testing. But it does have to be done correctly. And you've got to be careful about who you're recommending a biopsy to, and understanding that a biopsy is a big deal. You biopsy someone's prostate. It's a 5 to 10 minute procedure in the office, but it's incredibly anxiety producing, and it comes with some downside. The other thing that's important is now 20% of my patients are not treated. They're diagnosed with early, low-grade, slow-growing prostate cancer. We're going to watch that patient. And regardless of whether the guy's 50 or 70, we're going to follow this patient. He can maintain a good quality of life because treatment of prostate cancer comes with downside. So it's really important that we identify those patients that don't need immediate treatment, follow them appropriately and carefully, and make sure that we're not losing them, between the cracks, and that we're following them and making sure if they progress, they can be treated.
What's that continuous monitoring look like as far as you find someone that has the low grade prostate cancer? They're not high level. They're not the guy that's, stage 4 coming in. It's like, wow, this has been there a while. What does that monitoring look like over the years once that initial diagnosis has been given?
Yeah, so let's say we have a 52-year-old guy. He came in with a PSA of 3.5. We got a prostate MRI. He had a small lesion. We biopsied him. He had 1 or 2 cores of prostate cancer that was what we call Gleason grade group 1. Sometimes people identify it as Gleason 3+3 disease. So low volume, low grade disease. And we categorize that patient into a risk spectrum. So he's a low risk patient. And what I tell those patients is that you don't need treatment, because treatment, again, is going to come with some downside, but we're going to follow you. My preference is a PSA every 3 months, a repeat MRI, or a repeat biopsy yearly. The repeat biopsy, people look at me like, I'm not having another biopsy.
Yeah, no way.
Yeah. So we can follow that MRI. And there's some issues about the validity of that, but I like every 3 months. The standard is probably a PSA every 6 months, repeat biopsy or MRI in a year, and follow those patients. So if I see that this 52-year-old guy, he's got potentially 40 years of life ahead of him.
Sure.
And I look at him and I say, you know what? You and I may be talking about treatment one day, but right now we're fine. We know where you're at. We know you don't need treatment right now. I'm not going to compromise your quality of life by treating you. I take your prostate out, I could cause incontinence, erectile dysfunction. We're going to sit tight. We're going to monitor things carefully. When we see the PSA rising or progression on your MRI and or biopsy, then we're going to talk about treatment. So if I can spare you no treatment for 5 years and then treat you, I've improved your quality of life for those 5 years. It makes tons of sense. And it's been a slow adaptation by the urology community, but there's a lot of strong advocates for this. There's a doctor in San Francisco, UC San Francisco, who is a big advocate of active surveillance. There's one in Chicago the same way, and in fact they're all over the U.S. for that fact. And it's a really important way to approach this disease, and it's appropriate for good patient care.
So pardon my lack of knowledge on the prostate. Is it something where 52-year-old patient you talked about had a couple cores on his prostate? You were able to remove those. Is it similar to a liver where you can get liver cancer and they'll take out a portion of your liver and you can have another good 30 years of life? Is the prostate similar? Can you take out a portion of it and not speed up incontinence or erectile dysfunction and some of those things that you mentioned?
It's a great question. The standard, you're diagnosed with prostate cancer, it's confined to the prostate. The standard for a long time was prostate removal. And it used to be we made an incision and did that. Now we use the robot, or radiation therapy. And there's been evolution. So the surgical evolution has been robotically, and it is 100% better. But there are still downsides with that. There are multiple different radiotherapeutic ways to treat prostate cancer, and that has improved significantly. And the side effects have been mitigated because of techniques. There is also what we call focal therapy. And focal therapy is identifying prostate cancer in a patient. Let's say prostate cancer is in one lobe in a small area. Maybe it's a little higher grade and you want to just treat that area. You can do that with cryotherapy, freezing the prostate.
Really?
You can do it with high intensity focused ultrasound, also known as HIFU. HIFU's been around since the 80s. But the technology has evolved and the equipment has been better, and you can focus those high intensity ultrasound waves in that area. There are also certain laser treatments that can be done as a focal treatment. So the answer, Nate, to your question is, yeah, absolutely. You can do focal treatment and just treat one portion of the gland and virtually eliminate the risk of incontinence and in some cases erectile dysfunction. But the patient has to be the correct patient. And you really have to be a high volume center that does a lot of these focal treatments. You can't dabble in it. You can't do 4 or 5 a year. You shouldn't do 4 or 5 robotic prostatectomies or radiotherapeutic treatments either. You want high volume. High volume leads to less side effect and more effective treatment. So there aren't many high volume focal centers in the United States, but it's evolving and it's becoming a better way to treat sort of a focal prostate cancer.
For sure. So talk to me about your due diligence then as somebody comes in and it is that a little bit higher risk prostate cancer. I mean, we could talk about any of the cancers within the urology world. I mean, testicular cancer too.
Sure.
What's your due diligence in looking at that and saying, okay, here's the correct treatment. Laser is going to do it, or maybe we need the robot, or maybe we need, some other form of therapy. What's your due diligence in determining which one is best for that specific patient?
Yeah. I'll frame this.
It's a broad question. I'm sorry.
No, it's a good question. It's a fantastic question, and it's an appropriate question. But I'll frame this in being as transparent as possible. I'm a surgeon. I get paid to operate on you. I don't get paid to send you to the radiation oncologist or to the focal guy at the University of Michigan. I get paid to take out your prostate. So I'm incentivized to do that to you. And it becomes a sticky wicket. I always try to be as unbiased as I can with prostate patients. Let's say I have a guy that I think he's got higher grade disease, higher volume disease. He needs treatment. I'll present to him all the options that are available to him, whether it's a robotic prostatectomy, radiation therapy, or focal treatments, or one of the three. And one of the things I'll tell him, I'll really focus on surgery because that's what I do, but we'll talk about the side effects of treatment: incontinence, erectile dysfunction, really important. And if you're a 52-year-old, a lot of 62-year-olds, 72-year-olds, it's really important too as well. So you have to be, you got to be cautious in talking and making sure you're honest with patients. But I tell everybody, there's no rush in getting things done. You should have a second opinion and talk to another urologist. Every prostate cancer patient who is deemed needing therapy, go and see a radiation oncologist and talk to them as well. The patient needs to be, I always say it's not my job to take out your prostate. It's my job to educate you so that you can make the right decision for you. I think that's I learned that in residency from, again, John Donahue, the chairman of Indiana University when I was there. He's God bless him. He's passed away, but great guy. He was a no nonsense guy when it comes to that mantra. I'm going to educate you. You're going to make a decision that's right for you. So
the best decision is an informed decision.
An informed decision. And what we say is it's a shared decision making. I don't want people to look at me and say, well, tell me what to do. I don't want that responsibility as part of it, but the reality is that patients need to be a part of this whole decision-making process. They need to do their due diligence. They need to do their homework. They need to make sure that they're making a decision that's right for them. What I tell patients is, I don't want to see you 6 months afterwards and hear you say, I wish I'd never done this. And granted, it's going to happen if you have complications, but that's something I really want to avoid.
It sounds like the key thing for you is making the informed, or having the patient make the informed decision, and that could mean going out and getting a second opinion, right? Absolutely. Whether that's from you, whether it's from another urologist. You mentioned sending someone down to the radiation oncologist. Like, get Absolutely. Other opinions on your specific situation, because you're not the same as the last guy that was just in here 10 minutes ago.
Exactly. It's so important that patients understand that, there's always this mindset that I've been diagnosed with cancer, I need to do something tomorrow. I said, take a deep breath, do your homework, understand your disease. You don't need to rush into anything. Get second opinions, talk to somebody else. If you getting a second opinion after seeing me hurts my feelings, you need to go somewhere else. You need to find a better physician. I tell everybody, get a second opinion. Talk to your friends, talk to your family, talk to whoever you can, and just learn about the disease, learn what you have, and figure out what is best for you.
Yeah. With all the different treatments that you've talked about, somebody could say, hey, I heard this treatment's the best, I want to do that one. It's like, well, that might not be the best for you, and here's You're why. Right. And they might be like, well, I just want a doctor that's going to tell me that this treatment is going to work because I heard it's the best one. It's like, well, go get a second opinion then. And they may tell you the same thing I'm telling you. They may not, but at least you're doing the right thing.
Yeah. It's prostate cancer, common disease, complicated, comes with downsides. Again, I think I remember when the robot came out in the early 2000s, and I said flat out, this won't work. It's now the standard of care. I would never, and I never say never, but I do. The vast majority of prostate surgery is done robotically, and if you sat and saw two prostate removals, an open and a robotic procedure side by side, you would never want to have the open procedure. You would want to do the robotic procedure. The visualization is so much better. The blood loss is so much less. Sewing the bladder back to the urethra is done so precisely. It's really a great tool. The robot's an amazing story in healthcare, I think.
Hey everyone, I wanted to take a moment to talk about what I do outside of being the host of the Doctors and Dollars podcast. I'm the CFO of Grand Vision Capital Group. At Grand Vision, we work with high-income earners who make a great living, but still can't quite break through that true wealth ceiling. We utilize strategically chosen investments tailored for high-income earners. The question always at the forefront of our minds is, why wait for retirement to finally live when you can implement an investment strategy that will impact your life today? To be honest, most of the people we work with never even knew these options existed because their financial planner doesn't have access to these exclusive investments. So, if you're ready to finally turn your high income into real wealth, visit our website, www.grandvision.co, and hit the Take Action button in the top right corner to schedule some time with me. Or even better, connect, follow me on any of my social media accounts, shoot me a message. Now, back to the show. Is it the physician operating the robot through like virtual reality, or is it strictly the robot just understands its surroundings, knows where to go, and it self operates? How's that work?
No, it's all guided by the physician. But number one, the visualization is so much better. The way that one of the techniques is that we insufflate the abdomen with CO2, and that compresses these small blood vessels and prevents bleeding, so that you see much better. Open prostatectomies, I remember significant blood loss, and you really rarely see that in robotics.
Yeah, it's scalpel and cut.
And scalpel and cut. And so I think all in all, the robotic prostatectomy is a much better way to do things. But it still is there's a big learning curve in that procedure, and it requires a lengthy training. I can tell you one of the things I appreciate about surgery, and I've always appreciated about surgery, is that when I can touch and feel things, that tactile sense, I think is really important. That's the next iteration of the robot, how there's going to be some ability to have some tactile sense. And that was the biggest, one of the biggest issues for me, was the robot. I have no tactile sense at all.
Mm-hmm. So you perfect segue into where I was wanting to go with my next thought is, where do you see robotics? Where do you see artificial intelligence being most relevant in the world of urology?
I think artificial intelligence is going to play a role in robotics. No two ways about it. I think it's going to take some time. You look at these robots; they're expensive. Hospital systems buy them. It's not like you get a new robot every year or two. I mean,
how expensive are we talking?
A couple million, $3, $4, or $5 million.
Okay. All right.
And the business model, there are these little attachments on the robotic arms that are really doing the manipulation. Well, you can only use those a certain amount of time before they won't function anymore. You got to buy a new one. So that's how the robotic companies are capitalizing on things. And I get it. It's a business. I don't want to. I'm not disparaging that aspect of things at all, but I think our AI is going to play a role in robotic surgery, where the robot is going to see what you see, and AI is going to participate in that. It's going to take some time for that evolution. I think where AI right now has a broader appeal is twofold in what we do. Number one, prostate MRIs. You have an MRI of the prostate, you've got to read that, or somebody has to read that and assess it. AI can jump into that in a second and figure out accurately, theoretically, what is an abnormal lesion, what's not. They can grade the lesions. So it's going to play a role, I think an active role in the radiographic realm. The other area is going to be pathology. When we do prostate biopsies and look at the pathology, is this like I said, a Gleason grade group 1, a 3+3? Is it a 3+4? Is it a 4+3? What is it? Because that is something that would provoke treatment versus something like active surveillance. So I think AI is going to play a role in that aspect of things. I also think that in certain treatment arenas, we're going to see AI play a role. One of the things about radiation therapy for prostate cancer is that the dogma has been that if I'm going to irradiate your prostate, we're going to put you on a medication that will medically castrate you. It's called ADT, androgen deprivation therapy. And the dogma was, well, you're going to put someone on 18 months to 2 years of ADT around the time they have their radiation therapy, and they're going to have better survival. And yeah, for the most part, that's true. But you want to know who is a patient that requires ADT, and maybe there are some issues about length of treatment. Maybe it could be 6 months instead of 24 months. There's actually a company in San Francisco that came out recently that used AI to determine this. And their estimates were that 70% of men who were treated with radiation therapy and ADT did not need the ADT.
Mm-hmm.
And what's important here is if I castrate you medically or surgically, you will not like me. The taking away all of your testosterone will significantly negatively impact your quality of life in a big way.
For sure. So what I'm hearing is healthcare analytics. Anybody who takes part in healthcare analytics, or if you're a pathologist or a radiologist, get a little bit nervous about artificial intelligence, because those types of things, the margin of error becomes a lot smaller when you have artificial intelligence reading these things than a pathologist or a radiologist.
Yeah, I see AI being a huge player in healthcare, and I have a couple. One of my good friends lives in San Francisco, and he is an emergency room physician who's retired, but he's got an AI consulting firm that he started. He's a really smart guy that really knows healthcare AI, and he is up to his eyebrows in business. So it's something that's going to, it's in its evolutionary state right now. We're going to see it change, but it's going to be an active role player in healthcare. No two ways about it.
For sure. Do you see? I mentioned virtual reality earlier. Do you see a world where virtual reality comes into play with some of these treatments that you're doing with surgeries, things like that? Maybe not just necessarily in urology, but heart surgery, brain surgery, where they might have a tiny little camera and it's all virtual reality, and they can go in there and fix it. I always think about like a Magic School Bus when I was a kid, that cartoon. Is there something like that where they can get down into the blood vessels with a camera, and virtual reality wise, the physician can then create treatment that way?
I would never say never to anything. I think that
you said it earlier. That's why I asked.
I said it earlier. Yeah. I will always chew on that. The whole robotic thing, it just seems so unnatural to me, and to a lot of people. And thankfully, we're proven wrong, because it is a huge improvement in things. And the quick answer is, it's going to play a role. Our technological innovations and advancements are incredible. Again, I think it will participate in what we do. No two ways about it. I think it's going to play a role.
Yeah, it always makes you ponder, right? Like if you think back to like 1980 and somebody told you, hey, at some point in the future, robots are going to perform surgeries on, in men's healthcare, you'd be like, no, you're crazy. What is this, the book 1982? Like, are you serious? But now today in 2023, 82 was what, 40 years ago? Think of 40 years from now. 2064, what type of technological advances are we going to have at that point? Not only in healthcare, but in many industries. And sometimes it's hard to think about. It kind of makes your stomach hurt a little bit. But I mean, as far as we've come since even the year 2000, as it relates to healthcare technology, is absolutely incredible.
Yeah, I agree. I was having a conversation with one of my partners yesterday about this, and we both are of the firm belief that prostate surgery is doomed. It's something that's going to fall by the wayside. There's going to be so many better ways to treat prostate cancer, to identify prostate cancer that needs to be treated, and there's really going to be that individualized, personalized medicine where you look at someone's disease, and based on their genetics and the specifics of their biopsies, or however we're diagnosing them in 10 years, that's really going to have a very effective and efficient way to treat them. And it's not going to include surgery. I think surgery I love it. Surgery is it's one of the most amazing things I've ever done. It's really an amazing process to do that. But I think its lifetime is finite.
So you and your friend, like-minded as you are, you still see treatment being reactive, right? There's just going to be more advancements being reactive to prostate cancer versus more advancements in being proactive to avoid prostate cancer even coming about.
Well, it's interesting that you bring that up. There's a great book out, and I can't remember the name. It was about this woman, Jennifer Doudna, who won the Nobel Prize in Medicine for a process known as CRISPR, which is genetic manipulation, basically. And the purpose is obviously to prevent or correct disease. You identify things like sickle cell anemia, and you can alter someone's genetic makeup and quote unquote cure their sickle cell disease. It's an amazing process where we understand the fundamentals of how we're made and what happens to us over time, or what genetic information gets passed on from generation to generation. And we're going to be able to identify that. 10 years ago, I didn't talk about genetic issues to prostate cancer patients. Now I talk to every single patient about genetic issues when it comes to prostate cancer.
Yeah.
It's our gene makeup and gene structure and genetic abnormalities are exceedingly important.
But again, that goes back to my 1980 analogy. Like back in the 80s, they weren't thinking about genetics and DNA and how that can impact disease and things like that. And that's become more advanced of understanding and knowing how the body works and fights disease and things like that. And so
exactly,
yeah, that's very cool. Yeah, good point.
Yeah.
I'm going to shift gears on you a little bit.
Yeah.
Just thought of it because you mentioned him earlier. So tell me about a certain famous cyclist that you had an opportunity to be a part of some of his treatment back in the day.
Yeah, that was an amazing. I growing up in Southern California, my bike was my best friend, or my second best friend, and we all cycled to some extent. And then when I was at Indiana University, where I did my residency, Indiana was the world's center for testicular cancer. There were two physicians there. John Donahue, who was the chairman of the urology department, really revolutionized the surgical treatment of testicular cancer. And believe me, that can be a complicated endeavor. And then the medical oncology group there was really in the bright light in changing how chemotherapy was used to treat prostate cancer. Before that, prostate or testicular cancer was a death sentence. And after both the oncologic changes and the surgical changes, 98% of patients survive long term. So when I was in Indiana, Lance Armstrong came, and he had a very unusual type of testicular cancer. He had what's called a choriocarcinoma. And he had been down in Austin, Texas, close to MD Anderson, which is a great center. Went to MD Anderson, and one of the things about his type of testicular cancer was that he was going to get a chemotherapy that would create lung problems. And you can think, for the person he was, the cyclist and the endurance athlete he was, that did not bode well for him.
Sure.
The story is that he read a book written by a young guy that had surgery at Indiana, and that prompted him to come up to Indiana and find out what were his options. And they did things remarkably different when it came to his cancer. He actually had brain surgery to remove a metastatic deposit in his brain. But as part of
it had gone, because doesn't testicular cancer, if I understand it right, it goes testicles, stomach, lungs, brain. Or did I miss one?
Yeah, it's actually the lymph nodes behind the abdomen.
Lymph nodes. Okay.
Yeah, and then lungs, and then brain. But choriocarcinoma, most testicular cancer will spread through the lymphatic system. Choriocarcinoma has more of a tendency to spread through the vascular, the blood system. So that's how it got to the brain. Sort of skipped his abdomen, or what's called his retroperitoneum, and went to his brain. But as part of the evaluation, all of these testicular cancer patients were evaluated with what's called pulmonary function tests. And it's where they measure your capacity to, and because they want to follow you after your chemotherapy, which can create some problems with lung function. And I remember I was reading his initial PFT, pulmonary function test. and everybody said, wait a second, that's wrong. There was something wrong with the test. He's got to have that done again. So we sent him down to have it done again, and the result was the exact same. He was a physical. You can say what you want about Lance Armstrong, that he doped and he cheated like just about every other cyclist at that time, and he'll tell you he did as well. He took EPO, no two ways about it. But he was a specimen. He was a physical specimen that had something that most people don't have, and I think a lot of those high level cyclists have that. And I remember we were going around, and there's this cadre of residents and physicians. I think 15 people sitting at the end of his bed, and he had brain surgery 2 days prior, and he was putting his pants on, and they said, "Well, wait a second, you just had brain surgery. You can't go home." And he said, "Sorry, I'm going home." And he got dressed and he walked out.
Wow!
He was
2 days after.
He was a confident guy, no two ways about it.
Yeah, and he's had that arrogance about him, I guess, and everyone kind of knows about it, and it's fine. I mean, world-class athlete, and to all of a sudden get testicular cancer, has brain surgery. If he felt fine, I totally get it. But what was the room like? As he's getting ready to leave, was there, hey, you need more treatment? Hey, you need to be more observed longer. What was that like?
It's kind of funny. The guy is, supremely confident, and you talk to him today, and you get an idea of how confident he is. He was the same then. He was probably the same when he was 15 years old. People weren't going to tell him what to do, and he knew what was right for him. He's not a dumb guy by any stretch of the imagination, and he decided that he was done there. He was feeling okay. He was going to do the right thing for him, and off he went.
And then remind me, he didn't have any other surgeries or treatments thereafter, or nothing came back? It was just the brain surgery was all.
He had brain surgery. He also had a variant chemotherapeutic regimen. The standard was this thing called BEP, which was bleomycin, etoposide, and platinum. And the bleomycin is the thing that destroyed people's lungs. It was really a harsh chemotherapy, but they altered his treatment. I think he just got etoposide and platinum, although I can't remember. I may be violating all sorts of HIPAA here. But in any case, he was treated systemically for his testicular cancer, and obviously he's done quite well.
Is that BEP that's damaging to the lungs? Is that intravenous, or how is that
treatment? It's intravenous. Done? Yeah.
Okay. Has that changed? Have they gotten away from that just because they realized the damage?
Yeah, not really. The bleomycin, it's evolved somewhat. Initially it was either 3 or 4 rounds of BEP, and they've altered things somewhat depending on the patient's disease, and they have more specific ways about how to evaluate patients and determine what sort of chemotherapeutic regimen is going to work for them. But still, the bleomycin could be a problem for people. So, well, the etoposide and the platinum as well. Chemotherapy is chemotherapy. And one of the big things about chemotherapy is it's sort of this fight between its therapeutic and its therapeutic benefits and its side effects. So, and chemotherapy has evolved greatly. There have been a lot of changes in chemotherapy. So, it's a testicular cancer, not a very common disease, but a very, very, very treatable disease.
Yeah. Is that one of those, also back to my question about prostate cancer, is that something that can be just with diet, exercise, good sleep, some of the things that we mentioned at the beginning of the show, are those things that can also reduce the risk of testicular cancer, or it's kind of a genetic thing, you're going to get it and it is what it is?
Yeah, that's a good question. I think one of the problems is there's the numbers are so few and far between in testicular cancer, and
the data's not there.
Yeah. The data's not there, and a lot of people can be cured simply by removing the testicle. There's a large portion of people that's the extent of their disease. You remove the testicle and they're done, and they're cured. So, but what I would tell you is that there's more and more data that looks at things like diet, exercise, sleep, stress reduction. There's some really interesting newer data out of UC San Francisco looking at diet, exercise, stress reduction, sleep habits, as far as it's mitigating the progression of prostate cancer. You look at someone who's on active surveillance, who's been diagnosed with the disease. We're not going to treat you. Well, what can that patient do to forestall any progression of this disease and the requirement for treatment? Yeah, it's a plant-based diet, it's regular exercise, it's stop smoking, it's lose weight, it's good sleep habits, it's stress reduction. And all of those, it's easy for me to look at patients and say, change your diet or exercise or stop smoking. But the nitty gritty of it is that can be a challenge for a lot of people.
Yeah.
And I understand that.
Can't lead a horse to water, they say.
Yeah, it's a tough process. Fortunately, I've got a wife who's the militant vegetarian, and she runs the show when it comes to food, and she's a great cook. So I'm a de facto militant vegetarian.
There you go. Love that. Well, I'm going to wrap up with you. Talk about more of your personal side. You had mentioned you've cut back on hours. You're not having to be an attending physician as often as you were. What does that look like clinically for you? Like how often are you working now? As you've do I call it partial retirement? Do we kind of edge into that?
Yeah, good question. I'm sort of at my wife was sort of adamant about me slowing down and more adamant about me stopping at the end of 2022. That lasted for about I think it was 32 days until I went back. I like what I do. I like the patient interaction. I like the interaction with my colleagues. I like talking to you. This is good stuff. I think, but I also have other things in my life. I've got now 3, almost 4 grandkids. I missed a lot of my kids' activities growing up. I had 3 really good athletes and missed some of their high school and college sports events, and it was sort of gripping. And now it gives me the chance to be a part of their lives and my grandkids' lives. So I've cut back. Fortunately, in some regard, my partners still value me. I haven't been a detriment to them, and they like me as a person. So they're encouraging me to come back and help out, and that's what I do. I do it about 5 to 10 days a month, and it works out well for me. And I keep my brain sharp. It's a challenge. It's a great thing to interact with patients. I like talking to patients about the things I like to do, men's health, and it's been a plus. So yeah, I've slowed down. I was fortunate enough that my wife she's the financial guru in our house as well. She worked for McKinsey, and she knows her stuff inside and out. So she was very good at making sure that that financially we were in a good spot, and we are. So I don't really need the money, but the extra money is great, and I'm happy.
Yeah, and that's awesome to hear that. I mean, it's you can just see the smile on your face, and as you describe it all, and especially as you're talking about, like, hey, I love talking about urology. I love interacting with patients. You can just see the smile on your face as that you do love it. The fact that you have that financial freedom to be able to only have to come back 5 to 10 days a month is fantastic. It gives you more time. I mean, you mentioned your 3 sons being great athletes. You're a heck of an athlete yourself. I mean, you're in your 60s, I think you said. You're out surfing, you're out running, you're cycling. Talk about why men's health, even at your age, even compared to my age, why is men's health so important? Why is diet and exercise so important to just overall health?
Yeah, it's funny. I've always been athletically inclined, and I'm a marginal athlete, but I really get into the things I get into. And it's been good for me to go out there and cycle a lot, because I ride with a lot of younger guys, and there's a common phrase in cycling: we won't drop you, we'll just torture you. And it's a good way to think about things. Last year, my son, he said, "Hey, let's do a half Ironman," and it was a great thing. It was a challenge. It was great to do that with him. And to keep myself healthy. I mean, the years have taken its toll in some regard, and I know that if I exercise and I eat correctly, and I get a good night's sleep, and try to reduce the stress in my. I mean, we all have stress. We all have,
Sure.
have issues that are challenged. I get that, but maybe some meditation or yoga can help with that. So I've been fortunate. My wife is also very active, and we're able to do these things together. I do a lot of yoga with her, and we did a cycling trip to Utah recently. So I'm fortunate that I have my kids and my wife who support this and give me the opportunity to continue to be active and do the things I want to do. I'm in a good spot.
Yeah, that is awesome. That's so good to hear.
Yeah.
Last question for you then, just from a financial standpoint. You said your wife's kind of the guru. Uh, I can't imagine, and maybe she is the guru, but I can't imagine she did that all on her own. What were some of those strategies
No.
that you guys did as you were getting later onto your careers? Kids were out of the house. You knew at some point there was a half retirement or a full retirement at some point in your future. What were some of those financial strategies that you made sure that you guys implemented early on in your career that have then led to a sense of financial freedom at this stage in your career?
Yeah, I remember I have a degree in economics from the University of Michigan, so
Nice.
which doesn't it doesn't mean a whole lot, except I'm a big Michigan fan. But I I don't know anything about investing or finances or anything like
Mm-hmm.
that. And I remember there's a famous lawyer. I can't remember his name off the top of my head, but a lawyer who defends himself has a fool for a client. It's one of those things where I recognize that, and my wife understands this. She's a business, had the business mindset. She and I both understood that somebody smarter than us has to be able to give us advice and do the things that are right for us to keep our financial health, if you will. Just like I tell people, go see a physician. It's the same thing. I mean, I don't know A from B. I don't know how to mitigate tax burden and all the stuff that goes into that.
Sure.
I can look at stock market stuff and say, oh my God, I'm an intelligent guy, but that's beyond me. I can't do that. We had a really, really, really good financial advisor. It was a small firm. They were recommended by some friends of ours. Really strongly recommended. We met with them. They laid out this long-term plan. We did the whole 401k and did that. I had because of my work, I was able to get a 457B as well, which is one of those. It's another pre-tax investment, and we just kept regular contact with our financial guys. 4 times a year. I was out in left field. My wife was taking notes and doing all those things that were really important, and they kept us on track. And the bottom line is that we were able to build enough security and wealth where that we can kind of take it easy at this point in time, and we can help our kids with their kids' education, and we can buy a small house in Minneapolis and have the house in northern Michigan and be able to see our grandkids and see our kids. So we're in a good spot, and it's been helpful that somebody smarter than me and smarter than us was able to give us the advice that we needed, so that we were in a good position when we were in our 60s and be able to slow down from a work standpoint.
Yeah, that was a perfect answer, John. Because as you were talking, again, former financial advisor, I always want people to trust me and what my advice is and the direction that I lead them.
Yeah.
But as you were talking, I was just thinking like, man, if heaven forbid I have prostate cancer in the future and I come to you, I don't want you standing there getting ready to perform surgery on me, thinking about your 401k allocation,
right?
Or understanding, man, am I going to pay more in taxes this year, or should I have done
Yeah.
I don't want you to be good at finances. I want you to be really good at what you do in your profession. And again, let an expert. You said the second opinion thing, right? It sends somebody off for a second opinion. Same thing in finances, right? It's
absolutely.
There's always somebody smarter that can give you just a little bit different advice that just accelerates your wealth building into the future. So I'm glad you were able to display some honesty there and just be like, hey, I'm not that guy.
Yeah, I'm not. Believe me, I can make the biggest mistake in the world by doing that. And I, I I was fortunate that we found the right group of people to help us. And that
Mhm.
again, my wife is the one that researched that and did that, and she did our due diligence, if you will. And it was a great thing. My kid, my oldest son graduated from Cornell Business School and works for a consulting firm. My middle son worked for an investment bank for a long time, and my daughter works for Deloitte. And they want nothing to do with healthcare. They're all
Mhm.
smart business people, and they're the ones that look at us and say, and my sons have said it to me a couple of times. We're so glad you're in a spot where you're comfortable. It makes it so much easier for us, and now we have the ability to be friends with them again, and
Mhm.
they're off on their own lives, and but we have the ability to interact with them. So we're in a good spot.
Yeah, subconsciously they're just saying we just don't want to take care of you, Dad. So we're glad
Right.
that you took care of
Believe me,
yourself before.
that's exactly what they're saying.
Oh, that's awesome.
They owe me.
What's been Yeah, exactly. Well, it's been a pleasure, John. I'm glad we got some time together. Ran a bunch of topics by you, but man, you nailed it today, and really appreciate you taking some time out of your partial retirement in between
Yeah,
visiting kids and surfing to hang out with me.
I love this. I love talking about men's health, and I appreciate you taking the time and inviting me to do this. This was a fun hour. I enjoyed this.
You bet. Well, next time you're in Minneapolis visiting the kids, let me know. That's a couple hours north for me. I'll swing up and we can have a beer.
Sounds good. There's a
All
lot
right.
of good beer in Minneapolis.
There is a lot of good beer in Minneapolis. That's why I
Yeah,
said it. Thanks,
good
John.
deal. All right, Nate. Take care.
Hey, everyone. As we wrap up today's episode, I want to talk about the second opinion. As most of our listeners are physicians, you guys know the importance of having another medical professional's insight for a patient's treatment plan. But have you ever considered having a second opinion on your financial plan? Or have you simply trusted your financial advisor that they've already leveraged every strategy that your family needs to be 100% on track to meet your financial goals? That's why, for my Doctors and Dollars listeners, each Wednesday I block off 3 time slots, an hour each, to provide a free second opinion of their financial plan. During this hour, we'll reevaluate your financial goals and your risk tolerance. We'll ensure tax mitigation strategies are in place and ultimately give you confidence with your financial outlook, because that is what drives a happy home, a happy marriage, and peace of mind. These 3 spots each Wednesday do fill up fast. Send me an email at nate@grandvision.co or head over to www.grandvision.co/second opinion to fill out a quick form about you and schedule a time for us to meet. Thanks for tuning in, and I hope the rest of your week is abundant. Cheers.